Continuing on with chapter 35. So, behavioral emergencies um, can be relatively common with the geriatric population. Depression is pretty high. It's not a normal part of aging, it is a medical disease. Um, Depression is treatable with medication and therapy, but a lot of times it will go unrecognized or untreated appropriately, which leads to a higher suicide rate in the geriatric population than any other age group. And there's several risk factors for depression. Um, any sort of debilitation or um, lack of the ability to move around, loss of friends and family, feeling isolated, etc. Suicide. Most older adult suicide victims have recently been diagnosed with depression. They've seen their primary care physician within a month of their suicide event. Older men have the highest suicide rate of any group within the United States. And uh, older men also choose more lethal means than younger victims. So they have a higher chance of successful completion. Oftentimes, they do like to utilize guns for their method. There are common predisposing events and conditions. A lot of it is lack of productivity, being laid off from a job, loss of a spouse or close family member kind of tends to send them into depression, or a diagnosis of a long term disease. If a patient's displaying signs of depression, um, whether it's geriatric, whether it's pediatric, doesn't really matter. The most appropriate course of action is just to flat out ask him if he or she is considering suicide. There is a stigma about, well, if you talk about it, they're going to want to do it, and that's not true by any means. So we want to find out where they're at in their contemplation. The GEMS diamond, this is meant to help you remember what's different about older patients. So it serves as an acronym that kind of helps your thought process. The G stands for geriatric patient. So this is just supposed to remind you that geriatrics have their own presentation and compared with those that are younger. Be familiar with the normal changes of aging. Make sure that you treat geriatric patients with compassion and respect. E stands for environmental assessment. Assessing the environment can definitely give you more clues to the patient's cause of emergency. Oftentimes you'll see pill bottles, Kleenexes, those types of things, medical devices that can give you a little bit more information as to what's going on. And then preventative care is very important to the geriatric population. So you want to carefully study an environment and see what risk factors they have at home. Oftentimes they kind of forget that they need to survey the scene for a new environment, and that leads to more incidences of events. The M stands for medical assessment. Older patients tend to have a variety of medical problems, maybe taking numerous prescription, over the counter, and herbal medications for management. So make sure that you obtain a thorough medical history, not just about what's going on with them at that second, but what they all have going on with them overall. S stands for social assessment. Geriatric populations may have less of a social network. Could be because death of a spouse, family members, death of friends. So they may not have that mental support. And then geriatrics may also need assistance with just daily living activities, which can be very frustrating for them. You may need to get them some information on agencies that can help them out. Special considerations. Assessing a geriatric patient can be challenging because there can be communication issues, hearing, vision deficits, alterations in consciousness, or orientation, complicated medical histories, and then any sort of effects of medications. For scene safety, geriatric patients are often found in their own homes. They can be found in retirement homes or skilled nursing facilities, but more often than not, they actually live at home for a greater period of time now. So there may be problems with them getting to the door to let you in. So you may have to gain access, unfortunately. You need to take note of negative or unsafe environmental conditions. Look for clues that might explain the patient's medical history or the current problem. In a nursing home or residential care facility, you may need to locate the patient's room, find a staff member who can explain why you were called. Oftentimes, though, in full skilled nursing facilities, they have a greater patient to nurse ratio than you would in an acute treatment facility. And so they may or may not be as familiar with the patient as you would expect them to. If the patient's mental status is altered, try and find somebody that can give you some information because it's going to be hard to gain it from the patient themselves. And oftentimes, if they're in a skilled facility, they may not have a family member that's there to advocate just for them. Mechanism of injury or nature of illness may be difficult to determine in people that have an altered mental status or dementia. So you're going to have to get information from a family member, caregiver, bystander, etc. And you may not have somebody that's super familiar with the patient. So this could be pretty interesting. And then even if you do get some information that can lead you to the MOI, NOI, oftentimes their multiple and chronic disease processes are going to complicate your determination. For primary assessment, it's the same as anything else. Address your life threats of your ABCs, determine your transport priority, maintaining a high index of suspicion for serious injuries, even if the mechanism doesn't seem to match up to that. As you approach the patient, you should generally be able to tell if they're stable or unstable, sick or not sick. Excuse me. Ensure that the patient's airway is open. Just overall aging can inhibit the patient's ability to protect their airway. They tend to either have a decreased or lost gag reflex. Normal swallowing mechanisms can be decreased as well. So we want to make sure that we open the patient's airway appropriately. Check to make sure that there's no obstruction or possible obstruction. You may need to secrete. Anatomic changes definitely affect their ability to breathe as effectively and efficiently as we would like them to. Other than just the lack of gag reflex, they may lose a cough reflex as well, which causes an inability to adequately clear secretions. Any sort of airway issues should be treated with oxygen as soon as possible. For circulation, poor perfusion is a very serious issue for geriatric populations. There's several physiologic changes that can negatively affect circulation, including lower heart rates, weaker or irregular pulses. Vascular changes, circulatory compromise definitely may make it difficult to feel a radial pulse. So if you don't feel a radial, go ahead and try a central pulse, mostly going to be a carotid, before you start pumping on the chest. Any sort of circulation problems should be treated with oxygen as well, and determine if cardiac abnormalities indicate an acute emergency or if this is some sort of chronic issue for the patient. Transport decision. Oftentimes your patient assessment is going to be more complicated because multiple issues are going to exist. So we want to deal with any complaints that compromise the ABCs and transport them as a priority patient. If we don't have any problems with A, B, or C, we don't propose that anything is going to be life-threatening. We can do a little bit more of a stay-and-play type situation. But keep in mind that because of the decrease in neural capacity, the nerves not being there and strong like they used to be, you don't really know if the patient can tell how bad they are. And the geriatric population just doesn't have the reserves that the younger population does. So they will tend to decompensate very quickly without much warning. So you may want to consider ALS treatment and transport earlier and more often than not. For history taking, we're going to investigate that chief complaint, find and account for all medications, make sure that you obtain a thorough patient history, despite the fact that communication might be more complicated. Determine whether or not if they have an altered level of consciousness and if that's normal for them or not. For a sample history, you're probably going to have to rely on somebody to get the whole story, but make sure that we're talking directly to the patient, not the caregiver. Again, protecting their dignity. We're going to want to make sure that we have a list of all their medications and transport to a facility that knows the patient's medical history. Here, we really don't have that big of a luxury, so it's going to be whichever hospital the patient prefers or whatever facility that they align with. For your secondary assessment, your older patient might not be very comfortable with being exposed. They may be more modest than you would expect. And you also need to keep your patient warm during your exams. So making sure that you get a chance to inspect, palpate, auscultate, etc., but trying to keep the patient covered as much as possible. For taking your vital signs, your patient may not present the way that you want them to because of the medications they're on for their chronic heart conditions or just overall conditions. Medications called beta blockers end up keeping the heart rate low, and so you're not going to see the tachycardia that comes along with shock or dehydration because they can't compensate because of their medication. They may have weaker or irregular pulses. Circulatory compromise may make it difficult to feel a radial pulse, so you should definitely consider different pulse points. Blood pressure just tends to be higher because you end up losing some of that elasticity in the vessels. Capillary refill is not a good assessment. With skin changes, reduced circulation, and lack of ability to regulate temperature, it's just not really that reliable of a sign. Respiratory rate should be about the same range as younger adults, but you're probably not going to get the same chest rise because of chest wall rigidity that tends to occur with aging. And you need careful interpretation of pulse ox data because the pulse ox device requires adequate perfusion in order to actually get a good reading. So it may or may not be reliable for you. Reassessment, you're going to reassess a geriatric patient more often than an older adult because they may just deteriorate very, very quickly. You want to recheck your interventions, allow the patient to maintain a position of comfort unless there's something that prevents them from being in that position. Assist ventilations as needed. Administer glucose for a patient with diabetes who has an altered mental status and a manageable airway. You do have the ability to take a finger stick glucose. Keep in mind that with that delayed circulation, you may not get a super accurate reading there either. Oxygen is useful. Listen to your patient, respond to your patient, provide reassurance, and then document everything, including their history, medications, assessment, and then any interventions that you have performed. So here's kind of your overall guidelines, table 35-4. I'm not going to sit here and read this to you, but this definitely does give you some guidelines to follow. It is provided in your book, and I would suggest going over it. We will continue on in the next video.